morning, and thank you for the masterclass title also. First of all, I'll introduce myself a little bit. In 2007, I knew absolutely nothing about pain at all. And then I became a pain patient. And like most people, I thought, okay, I'll go to the doctor, they'll give me some pills, maybe I do a bit of physio, something like that. I'll recover, I'll go back to life as normal, but that wasn't the case, and I developed chronic pain. So I've been living with pain ever since and became interested in volunteering. I did that at the national level with the Irish pain organisation, Chronic Pain Ireland, became the chairperson there, then realised so many of the decisions in healthcare are political, and looked to Europe. Obviously in Ireland we have a very strong relationship with the EU, and the powers that be in Europe dictate a lot of what happens in Ireland, so we always feel like we can give back. But seeing the political advantage that you can gain in Europe was very important, and then I became involved to Pain Alliance Europe. I wasn't involved in the kickoff of this project because the previous president was still here. So actually I inherited this project. And I was a little bit skeptical at the beginning as of what have we agreed to do? Where are the patients going to fit into that? So really it's been a learning curve, but I'm very thankful for that. And so I've been president now for 2 years. Just a little bit specifically about my pain story, how that ties into the work that we're doing here is that I was an incredibly over-medicated patient. So at one point I was on amitriptyline, duloxetine, gabapentin, tramadol. When the tramadol wasn't working, then we went to duragesic patches, fentanyl patches, and I was like a zombie, basically. So yes, I had less pain, but I had no quality of life whatsoever. All of the side effects, from dry mouth to opioid-induced constipation, everything, the full spectrum of all of the complications of the medication. And really I had to decide how much pain can I tolerate, but to actually live as well, and take ownership of what it was I could do on a day-to-day basis, be it exercise or diet or managing my mental health, all of those things. What can I do to live? Because every time I stand up in a room like this, everybody says, you don't look like you have pain. Now I'm getting older, but they used to say, you're too young to have this kind of pain. So it's not always visible, but people only see you when you're well. It could easily have happened that it was a bad pain period. If there's a particular flare, we all know with stress with work, we perceive things differently. It could have happened that I wouldn't have made it today. So you only see patients when they're well. It's always important to remember. So this is really how I identified at one point on that journey. I burnt out. I went from being completely productive person to literally going from my bed to the sofa, back to bed again, and had to completely learn again how to re-engage with life, how to find a way to work, how to find a motivation to keep going again. I think it's a good story in terms of how patient involvement is so important, because without that experience and being able to stand here, I can't give you the truth of really what it is to be a patient. And you'll see what I'm going to go through now, which is PAE's work, how it's not just my experience that we're trying to share in these projects. How do we really amplify the voices of all patients in Europe that experience pain? So Pain Alliance Europe, if you're not familiar with us, we're an umbrella organisation of 40 national and regional associations across Europe in 17 European countries. And really for us, we tend not to get into the drug specifics. For us, the main thing is that patients should have access to the best possible treatment according to their wishes. So for example, you'll hear in all the different projects, psychedelic assisted therapies is something that we're really advocating for at the moment as well. So we tend not to get too specific, but access by choice for the patient across Europe. And that if I'm in Spain, or if I'm in Serbia, or if I'm in Finland, it is the same situation. How do we do this work? There's really 3 pillars to the work. The lobbying and the political work, that's through the societal impact of pain. And that's in partnership with EFIC, the European Pain Federation. We have a really close relationship with EFIC. In fact, we share offices with them. And we're very lucky for that, because we see the value in being backed by the scientific and that vast knowledge base from across Europe in all different kinds of pain and clinical areas. And then ourselves in terms of the strategy and really bringing the personal voice and the policy work as well. The Societal Impact of Pain Europe, that decides on the strategy, actively engages with the members of the European Parliament, really trying to influence the policy, not just in health, but also, for example, in employment and in transport, in justice, in all different areas as well. There's 9 national platforms across Europe, and they really bring things down to the national level then. For example, we have position papers on the cancer beating plan, for example, making sure that pain was truly addressed within the plan. And you can imagine from the scientific point of view what that looked like within the horizon calls, what was the funding like, who was to be involved, making sure it was really the best people, it was the most inclusive, but from the clinician side as well as from us as well. It really is a joint venture. Also, the workplace integration and adaptation, that was through the EU for Healthy Workplaces programme. It was mainly aimed at musculoskeletal conditions, but we developed a position paper on that, on how people in pain should be involved in the workplace, stay in the workplace, or be encouraged to return to the workplace too. And I think that really can be transferred also into the education system too. So people at student level, younger people as well. How do we enable them to stay or return back to education too, which is really important. It's not something included in that paper, but it's easily transferable, I think. Our most recent work really has been very busy in the last 3 years in terms of pain assessment and quality indicators. So pain is a key indicator within health systems, something EFIC are very passionate about. For us as well, the joint statement on pain and mental health. So we did that in a multi-partner way with the European Cancer Organisation, GAMIAN, the Patient Mental Health Organisation, European Psychiatric Association, European Federation of Neurological Associations, really a consortium of all of the key patient and scientific organisations across Europe to come together on mental health and pain, because we know that poor mental health is a predictor for chronification of pain and vice versa. And that isn't always clear if you're only in the mental health world. And we wanted to make sure that pain was included in this comprehensive mental health plan that's going through Europe at the moment. Also then, as we all know, for the first time, ICD-11, the International Classification of Diseases, specifically coded primary pain for the first time. Primary pain as well as secondary pain, and there's coding for that. And we were advocating a lot for the implementation at the national level, but also within Europe for all of the data collection, that ICD-11 be the standard that is used, because it's up to every individual member state to adopt it, of course, but we're really pushing that that's implemented, because we don't truly know how many patients are living with pain, to be honest. We all refer back to Breivik from 2009 or 6 or whenever it was. That's really the most widespread study there is on just how many people there are living with pain at the European picture. So we need better data on that, but we have to collect it in a comprehensive way. So the second pillar of our work then is a grant that we hold every 2 years. It's a patient-centered grant. It is very admin light. We try to keep it as easy to use as possible. We don't own any of the IP in the end or anything like that. It's very small in amount of contracts. We have a different theme every year, usually tied into the surveys that we do ourselves as well. So this is really the second pillar of our work, as I say, the Brain, Mind and Pain Patient-Centered Innovation Grant. It's being reinvented at the moment. Next year it'll have a slightly different name, but really for us the most important thing is that patients are at the centre of design of any of the grant projects. We've had a variety of different things, from social media campaigns to developing an app in Greece to tackle a stigma, then cognitive behavioural therapy for insomnia around the sleep theme in the last 2 years. The final results of those projects will be in April. So we try to also give back to the community too. Last time the pot was €60,000, and then there were 2 winners for that. So we're not going to be the sole funder of any European-wide multi-site research, but as a patient organisation, if you can then reach out and go, okay, we actually have some money, that really empowers patient organisations, because usually that's not the case. Usually it's the researchers and the clinicians coming to us saying, we have the ideas, but we also need a patient, trying to turn the power dynamic, let's say. Then lastly, and what I'll speak most about today, is really all the research that we either lead or participate in. So as I say, I don't want to speak to everybody only to my own story. While it's relevant to my own life, I want to be able to give the stories of patients from across Europe, not just my type of pain. So how do we do that? We do every year. We've had a bit of a gap due to COVID and survey saturation. We saw a dip in the numbers, and We found really people were, especially with online surveys as patients, there were too many. So we took a break for the last couple of years and we're coming back next year. But the first year was 2017 on diagnosis, treatment and the impact of chronic pain. We had 3,490 respondents in 17 EU countries. We always translate these into multiple languages as well. So for 2018 on pain and work life, we had 4,403 responses from 14 countries. That was with respondents greater than 50 respondents per country. Then in 2019, this was the greatest survey in terms of response rate and really impacting what we could do for our advocacy work too on pain and stigma. With over 6,000 respondents, that was from 28 countries, and that was actually translated in 14 different languages. In 2020, we looked at pain and e-health. And I think we were a little bit early in terms of the patients didn't really engage with the survey well. It was the one we had the most questions about. What is this survey actually about? I might have an app on my phone, but where does that fit into e-health or m-health? Or I think we were a little bit ahead of where the actual patients were at the national level. So timing was a bit off on that one, but interesting results nonetheless. 2020, we did a brief survey around COVID, like everybody. What was the impact on patients, especially in terms of access? And then 2021, we did a more in-depth survey around COVID. Then 21, we did diagnosis and treatment again. We repeated it to see if things are actually changing with some supplementary questions. And that the uptake was a little bit better at 2,203, 12 countries in 15 languages. Next year will be around self-management. We're really looking at trying to find some sort of agreed definition of what self-management is in terms of a systematic review of the literature, first of all. What we'll go to the patients with, though, is what is their experience of self-management in that? Did you do some sort of education program? What was the content? What was missing? What did you find? All of that. We really want to look at that because there's so many programs out there. Often it could be one physio develops a self-management program and kind of has it as a private industry, or you can have some attached to pain clinics. So it's really broad. But as a patient, you've no idea which one is better or what maybe is missing, for example, if it's your first time participating. So that'll be the focus for the grant and also for the survey for next year. We've also some recent publications. This is something that I was passionate about. The patient surveys are really for our advocacy work. We don't try to publish them or anything like that. It's really to capture that patient voice so that we can say truly this is what's happening for patients. But we have been involved in some publications, and one of them in particular I'm going to talk about the Delphi process that we had with Integrate Pain in developing a core outcome set of domains for 4 categories of pain, which I'm going to talk about today. Because this is one of the projects, while we have our own research, we engage with lots of EU funded research. As I say, there's the psychedelic assisted therapy, MEP action group, not an interest group. We're trying to do some action. Actually, it's very positive in terms of the EMA have assured us that next year they are going to approve psychedelic assisted therapies for mental health therapies. It's been a very quick progression in success. It's been a lot slower in pain, I have to say, but for mental health, really things are being accelerated at the moment, definitely. So the value of treatment is with the European Brain Council. We're doing a cost analysis in a pilot study in Germany on 3 different kinds of pains, so diabetic related neuropathy, fibromyalgia, and low back pain, and seeing if you treat patients in the ideal way, so the optimal treatment for patients in terms of times, access to the best levels of quality care, and then compare that with suboptimal treatment, which in a lot of cases what is most accessible to patients, and compare the two, but also within a fiscal model. So are there any savings, for example, if you do things right? And thankfully, we're having some positive results there, where usually what I always hear is that, oh, if you want multidisciplinary biopsychosocial, it's going to be more expensive because you need a bigger team or whatever. But in the model so far, we're seeing that actually, especially longitudinally, you're saving the money. So the results are yet to come in on that. The work continues. QSPainRelief, obviously, as we're all here. Neuron, EarNet Neuron. Pandos Pain and Opioids After Surgery. It's not myself that's involved with that one. It's based in the UK. And I checked how long it's going. It was approved just last Christmas. And it's a year, 6 months and 30 days. I don't know why that's not a year and 7 months, but that's what was written. And that's really looking at longitudinally within that amount of time, what are people's opioid use after surgery? So following up with patients, and that leads into a lot of work around developing these guidelines relevant to Europe around opioids and surgery. And there's a lot more work happening with that with EFIC and others. At CHUDE then, we were the first patient organisation to host a secondment within the Marie Curie education programme. So we hosted 2 PhD students, supervised them from the patient perspective, which really took a lot of work to convince the EU that that was actually relevant. So we've done that, and they were really looking at stigma within functional disorders. Safe Polymed then is a relatively new project looking at reporting of adverse events for all kinds of medication and streamlining that in the EU so that there's one point of contact that any patient can go to. And that's literally just started. We're doing a Delphi process on what that can look like. OECD then, we're part of the Paris-NEAN registry project, and we're going to launch a survey around what patients' experience of engaging with the registry is like, because the registries have existed now for 4 or 5 years, and they haven't really evaluated, were the materials we gave to the patients good enough? Were they just, as often happens and can be guilty of it too, we're doing some research, can you fill this in? But what information were they really given? And then Integrate Pain Consortium, which I'm going to speak about, again, has just been published on the 4th. So a couple of days ago, I can finally talk about it, about getting these domains for studying pain. So that's an idea of PAE. We're doing quite a lot in lots of different ways, as you can hear. These alone are some of just the ERANET Neuron projects. You can see how it ties into the rest of our work, from improving translational research for chronic pain. That's a 1-year study. So this is within trying to network, almost like a cost grant, trying to get the network together to then actually do the research rather than getting everything done in the 1 year. We're not ambitious. Also, Agora in advancing guidelines with original research achievements in pain, very much a translational piece of work as well. StimCode then was around brain stimulation, and we developed guidelines around what is the safest and the best way to approach non-deep brain stimulation in mental health and chronic pain. And then PRIZE as well is another one of these projects that is coming up. But what I'm really here to talk about is public and patient involvement. When we're looking at public and patient involvement, there's a few working definitions. Participation is more when you're recruited to actively be part as a study participant, whereas engagement is efforts aimed at raising awareness. You might be on an advisory board, maybe. You engage in activities that are required both for participation and involvement. And then involvement refers to co-creation and co-produced research with the focus on collaboration. So really the difference between participation is I'm part of the research, I fill in the surveys, I go to do the card testing, whatever it may be, or actively I decided what I was involved in, priority setting, all of that kind of thing throughout the whole project. So it's very different what actually the different levels of engagement for patients. So the Irish Health Research Forum have said that it's occurring when individuals meaningfully and actively collaborate in governance, priority setting and conduct of research, as well as summarising, distributing, sharing and applying its resulting knowledge. So I think in a lot of cases, many universities are doing this to some degree, but not necessarily in every project. And what I hear time and time again is don't really know how this could work in terms of maybe in translation, but in basic and fundamental science, why would we involve patients? They don't understand the processes. Where can we actually involve patients? But because so much of the public funding now, it's required that you involve the patients. As an organisation, we're getting a lot more requests to be part of it, but also the impetus is on the researchers for all of you to join this gap, because the research carried out is really by patients or members of the public rather than to, about or for them. Why do patients want to get involved in research in the first place? Well, in a meta-analysis of patients' participation in various different research projects, they found wanting to help others, contributing to the healthcare system. They might have an actual interest in research. Altruistic reasons, working towards the greater good. I want someone to have a better experience than I had. These kind of themes as well. And also to be able to share their specific experience. And I think that's something that can be quite empowering for patients. First of all, to be able to say, this is what happened to me. And then when they're in a group setting, hearing that I'm not the only one. We may not have exactly the same type of pain, but usually the challenges are the same. And that can be really rich in terms as a resource to tap into when you're designing some research. So how and when can patients be involved? So if we're looking at the research cycle, we would say at every stage you can involve patients to some capacity. And you have to consider that when you're recruiting the patients in the first place. This is really just showing the flow of the cycle, first of all, but also all the specific tasks that patients could do, which I'll go into next. Because at the moment, the reason there's a giant reality is that patient organizations and patients are usually approached when the research question has been decided, the methodology is already decided, who will publish, what will the IP be, who owns which part, which university will do that, but we need some patients to be eligible for the grant, so let's approach some patients. And then the patients look at the project and they go, but maybe could you do this? And they go, this is the project now, but we'd just like your involvement, please. That is the reality of how most researchers engage with patient organizations, is when everything has already been decided. And thankfully, there is a shift now, and this project is an example of that too, where really at the very beginning, from the research call, priority setting, touching base with the patients, getting into with the patient organization, going, what is important to you in this area? We're not saying you can go to the patients every time and just from a general, what do you want? I know it needs to be more specific than that. You'll always get the same answers. We want better access. We want it for free. We want it quicker. We want more time with our doctors. You'll get the same answers. So within whichever parameters, what is it that's important to you with that? And crafting out of that then, with your own interests, of course, too. I know there's specific areas of interest people need to cover, but incorporating that patient view. Because what it means in the end is better patient engagement. And also when you're recruiting, it's easier to recruit patients. And those patients can help you evaluate the patients that you are involving in the research. So lots of tasks here. Briefly, I'll go through. So agenda setting, really identifying and generating the research topics or questions. That can be something as simple, especially now with Zoom, a focus group before you even have a survey to hand to a patient. Just that discussion around, okay, you have neuropathic pain, we're looking at side effects. What is the most challenging thing for you in this area? What would you like to see to improve? What's actually working really well? So is it easy to report when you have a side effect? Is that something you know about? That could be a 1-hour conversation, a very rich conversation that then could inform a survey, for example. Prioritizing topics for research, providing patient perspective on outcomes that are important to patients and their families through patient-centered outcomes or patient-reported outcome measures. Then in the funding itself even. So when we're looking at priority settings, according to the patients, where would you be better spending the money? That's somewhere else the patients can be involved. Designing procedures, advising on development of surveys, interview guides, advice on the scope and research strategy for reviews, the feasibility in conducting the research in the real world. So how can you actually get the patients to respond? Is this in a language that's accessible? Does it sound interesting? And when the patients are there from the beginning and they have an understanding of what you're trying to achieve, they can help you reach out to those other patients as well. Advising on outcomes that matter to them and the public. Advice on sampling. What would be a representative size? Especially if patients are involved in a patient organisation, say for something like complex regional pain syndrome. They have a fair idea of how many other patients they know of, their experiences. They can really add a lot in terms of the real world of what's happening. Developing patient information materials, reliable resources of information, advising on ethical issues such as consent processes as well. And I think since we developed this, also advising on data management too is another big area. It's like, how will the data be stored? What kind of data? Really, what does anonymized data mean? These are all day-to-day things for yourselves. You're handling data all the time, but it's not something you come across in your day-to-day life. Otherwise, apart from you go to a website and they ask you about cookies and you tick yes or no maybe and you just do it. You know, you need to use TikTok and you just agree to the terms because you want to use it. So really, you have to remember that from the other side of things, you don't encounter things like data sharing agreements all that often as the person in everyday life. And then you might be asked to be involved in researchers go, well, can we have access to your data? And patients don't really understand what that means or how sensitive that data could be. I know with the European Health Data Space, for good and for bad with GDPR in terms of how you can all access from other countries. I know that can be a big restriction, but really the protection for patients is obviously so important too. So being able to explain all of those things to the patients and getting their feedback as to what's really important for them, because many actually don't want to be anonymized or are happy to give the data for the next 10 years or 20 years if they truly understand what it's going to be used for. What other tasks are there? Okay, recruitment of study participants, the actual data collection. One project we had one member of our board that was responsible for engaging with all the people who were trying to recruit in a survey for our project. So the project, say, for example, if it was QSPain and the survey that's coming up, anybody that had any questions about the survey, instead of going to the research team, they could go to that patient who could, in the patient language, explain to them what the survey was about, how long it really took, all of those in a human kind of way, and sort of as an intermediary between them both. And that can work really well. Data collection, as I say, but things like contributing to the literature reviews, identifying the themes as well that come out of those reviews. What is it that stands out as a patient view? Co-generating data, then the data analysis itself. And usually what we're commonly asked to participate in is the dissemination. And if you haven't been involved in all of the other steps before, dissemination is more than likely a post on social media maybe, or you might include it at your board meeting to mention we were involved in a project, here are the results, and that's as far as it'll go. But when patients are truly engaged and involved in research, that's when the true dissemination happens. Because like myself and the work I was involved with, anytime I'm speaking now, I'll share that because first of all, I actually understand it. I feel like I was involved with it and that it was representative of the patient experience. Then facilitating uptake. So that's where you need a more organized approach. Obviously, the patient organizations ourselves with the lobbying work we do. So great, we find these results. It's all relevant to patients. It's in patient language, all of this kind of thing. Also academically published and everything that all the partners need. But what happens after that? How do we make this translate into the real world? And that's where you need the patients, especially for lobbying at the political level. Of course, you need the accurate information from the scientific point of view, but really the lived experience we found is what convinces MEPs to make change. And then lastly, evaluation of the research. So if you're involving people in your project, evaluating what that process was like. Maybe we only needed to engage with you about dissemination, but what was that process like? And then being able to bring that knowledge forward to the next project that you're doing as well. So one example of such a project would be the Integrate Pain, which was a collaboration between the IMI Pain Care in Europe and the NIH. It was just published on the 4th. You'll see what the results are. But there was work already happening in Europe around, say, for example, post-surgical pain that I mentioned earlier and opioids, but really how do we measure the patient experience within all of this? And in North America, we're also interested in that at the government level too. So the two forces came together and decided to develop a Delphi process to agree on a core outcome set of these domains. So how did we do that? So we generally met all at the beginning, as I say, IMI Pain Care and NIH, patients and other stakeholders too, for the very first meeting to see, is this relevant, first of all? Is this something that people want, need, or would actually use? They did a systematic literature review, really identifying what were the domains that are currently being used, where were the gaps also, and they presented that back to the stakeholder group so that we could also give feedback around, are there gaps that we identified that maybe weren't in the literature? Then we had a domain meeting deciding on which of the domains should be included and not. And then we had 3 rounds of Delphi voting. And then we finalized 4 core outcome sets with those domains. So the voting started in July of last year. And as I say, it's just been published. And what did we actually find? Well, first of all, we had to define which kinds of pain we were going to develop the outcome set for. So we decided on, rather than condition specific or pathology specific to individual pain types, it was broader categories. So acute pain, the transition from acute to chronic, recurrent episodic pain, and chronic pain. And chronic pain had the most amount of patient responses, but it was all weighted equally between the clinicians, the researchers, and the patients. So from the literature, the review of the finalized down to 62 articles, and then there were distinct domains within the literature. For acute pain, there were 30 distinct domains, 241 for chronic pain, 19 for the transition, and 29 for recurrent or episodic pain. And then the Delphi process, within 3 rounds of voting, in the first round, there was all of these domains. We had to prioritize within our own fields and expertise what is the most important to us. But there was also the opportunity to suggest ones that hadn't been included there as well. None of those actually made it to the end, but there was that opportunity to fill in the gaps, let's say. Before I go into the actual results, we're talking about the domains around the measures specifically for patient-reported outcome measures. I'm talking about patient involvement. And how many of these domains do you think were actually validated by patients in terms of the content? So were patients involved in developing any of these domains? When they already exist, does the content truly represent the patient experience? So if I'm filling in the Oxford knee and hip score, for example, does that really fully encompass everything I experience with knee or hip pain, for example? Any idea of what percentage of these PROMs actually involved patients or were validated by patients in terms of content? 17% is the answer. So we all know this huge drive for these data sets, and don't get me wrong, we need patient-reported outcome measures, but we have a lot of work to do around, are these truly capturing what the patient experience is? And I think that points exactly to the driver of having a core outcome set in the first place, is that this is the core, but if you have the individual in front of you that's saying actually sleep or something that isn't in the core outcome set that's actually really important, that'll come through in the results, why wouldn't you also give a questionnaire or do a reported outcome on that as well? But it's actually the actual content of those questionnaires, though, is that these are now becoming standardized, but I think we've skipped a step in terms of, are they really asking the questions? Because there's more and more research into this also. For example, that Oxford knee and hip score, it's been shown that you would need to combine 5 PROMs around knee and hip pain, for example, to get one that actually encompasses the full experience. And we're never going to have one questionnaire that asks all the right questions for all the right patients. And if you did, it might be 700 pages long and it'd take 2 days to fill in and nobody would answer it. That's the reality. I completely understand the challenges of that. But that doesn't mean that we shouldn't strive for better. We're recommending this now as we do. You can see these are the domains that were agreed upon. We didn't go as far to say the specific questionnaires that should be the PROMs, which specific ones should be used within these domains. So it's an overarching set for each of those 4 pain categories. While there was working definitions, and you can see when you go to the paper how from the literature review what those domains specifically mean, but these really are overarching. So if you have a preference of one depression score over another depression score, for example, and that's what relates to your patient, then of course use that. It's up to individual choice. But when we're looking at large data sets, we need to be able to agree on a core set for standardization and these huge data sets that we need for conducting, which I heard all yesterday, we haven't got the data. We didn't have access to the data, all of this. So we need to be collecting the same thing at least. So what were the final outcomes? So for acute pain then, pain within the 2 subdomains of pain intensity and pain interference, physical function and quality of life. And we had that conversation yesterday around, well, what is quality of life? That could be 60, 70 other subdomains in itself. One of the domain that didn't quite get voted high enough to reach the final 5 was analgesic use. And this actually the only time it appeared was at acute pain. So I know there's a great focus in this around, abuse and the risk side of medications and things like that. But that didn't actually factor in terms of priorities for anybody, including the researchers in the other domains. So the transition then, pain again, pain intensity, interference, physical function, quality of life. The 2 that didn't quite make it were psychological functioning and sleep. So you can see that there's a lot of choice in that, whether you include them too and the time all of that kind of thing. But the core would be those 5. For recurrent and episodic pain then, pain temporality, pain interference, activity limitations, quality of life, specifically around health-related quality of life. These were all defined specifically. I just don't have the time to go into them specifically. And there wasn't anything else that came close in the voting. And then chronic pain, which is probably the most relevant to us all here, must include pain, intensity, interference, activities of daily living, quality of life. And then the 3 that came close were physical functioning, psychological functioning, and quality of life, specifically to physical quality of life. I think when you're looking at all of the things to measure, how you live, what you're experiencing is more important than what patients would see as a side effect. There might be abuse liability, as you would say, or a risk of addiction. I think there's also a reluctance to measure that, especially in Europe, because we've seen what's happened in America, and we kind of want to say, we don't have that issue in Europe. And if I was a patient to vote on that and say, that's in my top 5, I know that every time I go and see my doctor, then I'm going to be asked the question, how much are you taking? Is this safe? This isn't right for the long term. And all of that conversation that would happen. There were chronic pain patients from across the world. It wasn't monitored whether they were on medication or not. So there were clinicians, researchers, and patients that all went through the Delphi process. It wasn't just patients, and it was equally weighted between each of the stakeholders. So it also didn't come through. It wasn't that it came through for the clinicians and the researchers, but the patient said no, so it didn't make it. That wasn't the case. The pain intensity, interference, physical function, and quality of life, as broad as it is, do you think that can be transferred then to basic and fundamental? Do you think in some of those domains are things that can be addressed in vitro and in vivo? Intensity, interference. Also, we're not developing rodent reported outcome measures. I understand that, but if we understand that this is the end point, in that this is what patients, clinicians, and researchers want at the clinical level to be measured, in a translational point of view, are there elements of that can be brought back? So obviously I'm also asking to stimulate some kind of discussion in terms of, but if we're not thinking at the beginning of the end point, understanding what would be measured at the end point. So in terms of in patients, knowing that then from the beginning of the other end of the research, because it makes translation easier, I would imagine, but I'll leave that up to you. I don't think we're going to use patient-reported outcome measures only to decide all research questions. I'm not suggesting that for a moment. I think it's just something to consider. And say, for example, within this project, when we're considering which side effects, for example, to monitor at the preclinical, I think obviously touching the patients in the first place and finding out which of the side effects they maybe thought most impacted on them or most common could very directly have prioritized which ones were studied, as an example. When you're looking at the end goal of trying to improve the lives for patients, if you're not involving them and you're in silos, which is easy to happen because of the structures that already exist. I fully acknowledge that. I'm not saying this, I have a perfect system to propose and patients will be everywhere. I understand that there's challenges with that. How the papers are published, if you're a multidisciplinary team, all of that thing, everything is very individual in specialties. I completely understand that. But we can do better, is all I'm trying to say. But also within the projects themselves, okay, they mightn't have been able to take the time to involve patients in proposal, but if they have an actual patient, to use them within the project as well. You already have them at that stage. You must have them because of, if it's public funding, for example, so use them at least. How patients are actually being engaged at the moment. There was a meta-analysis from 2021, so it's not coming from me. This is from published articles. So how are patients actually engaging with preclinical and fundamental science at the moment in recent studies? Now, this isn't specific to pain, it's specific to basic and clinical. So these are some of the studies, but it's not necessarily about the studies, but what the tasks the patients actually had within the projects that were being represented by the papers. So who was it that they partnered with, but which were the roles that they had? So they had the roles, things like managing the social marketing, community outreach, engaging with the health system, designing and being involved in the education, funding. You can see the big one there around priority setting, study design, not in data collection as you would expect or in data analysis, but in the dissemination of the results. And then after these projects, generating that awareness. So more than dissemination, bringing it out into the world in real world terms of what is the issue? What did this solve, if anything? What did it make better or not make better in very basic terms? Which challenges are presented by involving patients? It can be time consuming, for example. There's costs that aren't necessarily easily recouped. Recruiting the actual patients as well is a huge challenge. So if you have a patient that handles a European organization that, okay, they have members in that state, they don't work at the national level. I also don't speak Dutch, for example. So when it came to all the materials and literally calling patients saying, that's the national organizations that will do that, not ourselves. But I'm the partner that was in here, I can give the higher view of it. So who was given the task? I mean, as broad as it is, even in priority setting. So do you want chronic pain patients in general? Do you want a patient specifically with neuropathic pain who's taking a certain kind of medication? You need to be very focused on which kind of patient you want for which task. We're saying about, okay, involve, but you need to know who you're looking for also. There's a great output from the project in terms of we held this event, but the one thing that was cut on the day was the patient input. It's a learning process for everybody. You really need to utilize the resources that you have. And even Ilona obviously was disappointed with the turnout as well. Well, I'm not going to speak for anybody, but for a patient event, but not one patient saying anything in front of everybody is questionable. Let's be honest. These are the challenges. And I completely acknowledge that nobody knows how to do this perfectly. You won't always get the result that you want. I could promise 20 patients. I can't always deliver 20 patients. It's the reality of working with patients and the challenges. So we're not saying we have it all right. And even with the online surveys, you're more likely to attract the people to share a negative experience, that they want to complain about how everything is. And that's their motivation in terms of wanting things to change because it's all so terrible. And in the past, patient engagement, I think why we're having all the challenges now is that it's been very adversarial. I mean, I've been at patient meetings and, you know, you invite a speaker who runs a pain clinic in Dublin, let's say, and you invite him to a pain event and he's faced with the patients and all they want to say is, well, I was waiting 4 hours, you know, the frustration. So there can be a bias. And the only reason I want to be involved is to make my point. Can be the kind of patient you attract. But even for the Delphi, I mean, it was very a North American response. It was in English. It wasn't a very diverse population that answered it. I mean, when we look at challenges in terms of, especially now, digital literacy, for example, is a huge challenge when everybody's developing apps and all of this kind of thing. So there's bias and there's skill sets that there aren't always the resources at the patient level or within these projects to really educate and find maybe specifically the right ones. We have to define control there, I think. Yeah, control is a tricky word. How do you truly control something if you don't understand it also? How much successful lobbying do you really think is from the patients or how much is it from industry, for example? I mean, if you think of control of patients in comparison to industry control, I mean, it's a very different story, yeah, about influence. An experience similar to what patients feel also, though. So can you imagine being part of a clinical trial and you've no control of having access to the information or where you fit into the picture, or was I patient X that was the only one who had adverse effects and nobody else did? But it's representative of that experience. For us, we're industry supported. We've good relationship with the industry. They're a necessary stakeholder within the community. There's good and evil in everything, in the patient groups, in industry, in science, in the structures that are there. I'm not pointing any fingers. There is a hesitancy. I think we saw it for the last European Pain Congress in terms of how much support they're willing to give to pain. Also, nobody's bringing, there's very little new to market also. So in terms of budgets, there's not much happening. Because of the litigation in America, they're wary of working with patient organizations. Even in Europe, we're seeing that. I mean, we have one member of staff, we're very small. I'm voluntary, my time is voluntary. We have one member of staff. I have a board, and because of funding, our member of staff is finishing in December until I secure the funding next year. That is the reality of it. But without industry, we also couldn't do it because the EU funding it's so conditional. Also, you can't be more than 50% funded by industry to be eligible for the maintenance grant, for example, in the EU. So where do you get the other 50%? I don't know. There are huge challenges, yeah. But I think what came through in the meta-analysis were exactly these challenges as well. So what are the barriers? This was specific to the basic science. So the different priorities, defining what the population, creating that relationship, the safe space, all of these kind of things. have the ability to be able to develop the strategies ahead of time, exactly like you're saying, preparing actually the proposal in the first place. All of those sort of things were recognized in this paper too. But what came through quite strongly, though, also were the benefits. As many challenges as there may be, really, there was the biggest learning for all of the papers that were reviewed was mutual learning opportunities. The patient event being an example. The patient's organizations understand better. The project understands better. It's a learning opportunity because, okay, it might not have been a great success in this project, but you take that learning on into the next one that you do. You've built up those relationships or lost some relationships in some cases, who knows? So this paper obviously reflected that. So really the considerations, if I'm going back to public and patient involvement in research, really what are some of the key considerations are around literacy, health literacy, digital literacy. These are things that are often overlooked, I think. The respect, plain language, there's lots of advice out there now around lay summaries, around lay proposals, guidelines on the language that can be used. It's all freely available information. The inclusion and diversity. And I know as who is going to engage in a patient organization, we're not diverse. It's something to really represent all patients. We need to find more patients to engage at every level from diverse populations. And the adaptability too. Things to consider in a very practical way are the pain levels. So you might have 20 patients having a bad pain day and they don't show up to your event, is the reality. The concentration level on the day, and also when you're designing surveys or you're designing a test, how long can that patient actually either sit there or be focused or actually be able to give you the feedback that you need? And that involves some testing, obviously, as well. The comfort, timing, and then travel. These are all just very practical considerations. Because, as I heard yesterday, the vast amount of work that all of you in the room are doing toward the greater goal of preventing pain chronification, understanding this, making the lives of patients better overall. I understand that. We just need to do better in involving the patients, but also all the work that you're already doing, giving that message back to the patients better too, because there's a lot of good happening. The picture is quite optimistic. We're understanding pain better in a lot of ways, and that message needs to go back to the patients too in a better way. Good discussion in general. Here's some of the resources. I think this project, having been in it, I do this presentation usually to people when I haven't been involved in the project, so it's nice to be able to give specifics. It was only a broad overview, but I would say reach out to your patient organizations because they want to be involved. They may not be skilled, they may not know how, but they do want to be involved. And get in touch with Pain Alliance. Let us help enable that relationship also. So we have members everywhere, as I say. We don't know everyone. We need more and more diverse, but reach out to us. So I'm really heartened by all the work that's happening in the project. Thank you for involving me and my input, and I wish you all continued success in our last year of QS Pain. So thanks for your attention.